Before we start with the next topic, I want to have kind of verbal feedback from all of you for the last session. Any afterthoughts after the facilitation skills session? I had sent a document also to all of you on facilitation skills. Whenever you get chance, have a look at that document. It will give you good insight into how do you go about facilitating your program effectively. And every time we will do, I think we'll find something new to learn or implement. So it's a process, it's a journey. Facilitation is a journey. Slowly we will become pro at it. Anything that you want to ask or say, anybody? Not really. Okay. So as discussed last time, from this session onwards, I'll be taking one short topic related to clinical communication. So the session would be covered with the intent to help you to integrate that topic in your program when you are working with different healthcare providers, doctors, nurses, paramedical staff, front desk staff. So the idea will be that how do you use this topic to help your uh, audience learn the right communication. So it will be more like practice session for you, learning, and then you will be, giving it a thought how you can use it for different categories of people. So the topic that I have used or planned today is understanding patients' expectations. So I want to understand from you, what do you think about understanding patients' expectation? What do we mean by understanding patients' expectations?
Maybe it's to do with what the outcome that they expect during the consultation. So I read this book called The Good Practice Communication, and I think that outlines this in detail, that patients expect that they should be given some sort of emotional couching, curative aspect of treatment. My understanding.
That's good. I think that makes sense, no doubt. How about others? Yeah, Beauty, you want to say?
Yeah, ma'am.
Yeah, sure.
So there's a very superficial understanding about what a patient wants in terms of when a patient walks inside a hospital or a doctor's room. There are many aspects which are unknown or overlooked in terms of a patient wanting to be respected, wanting to be the feeling of equality and the feeling of respect and privacy, confidentiality, etc., which is overlooked all the time. Everybody believes, at least the ones who don't know how important communication is, they believe that it's just a patient has come to get cured and doesn't matter what else is around that. So knowing all of that and understanding all of that is what is understanding patient expectation.
Wonderful. I think you have given a great insight into the topic and you have made a good beginning for the topic. How about others? What do you feel? What are patients' expectations? Yes, Dr. Hemant, please go ahead.
Good evening, ma'am, and good evening to all. Ma'am, I believe the patient's expectations are first built on what kind of our brand value is. So a patient, when he goes to a private clinic of a doctor and to a hospital or to a public system, is entirely different on different expectations. And whether it is a paid service or whether it is elementary or it's a camp, the financial implication of it, the time spent on it, and the reputation which the brand comes. So if a person goes into a very high reputed hospital setup like AIMS or Zipmar or Apollo or Medanta, goes with a different kind of mindset than to a nursing home or a rural health setup.
Correct. So that means depending upon the facilities, scope of services, and also the brand that it carries. People would have different expectations. So when we go to a government hospital, we have different set of expectations. When we go to a private hospital, corporate hospital, we have different set of expectations. Perfectly understandable. That adds to understanding of patient's expectation. Any other version or any other idea about understanding patient's expectations? Anybody else? Yeah, please, Dr. Santana, go ahead.
Ma'am, I would just sum it up as, if I am a patient and if I am in any hospital, what I would be looking forward to, number one, is the clear-cut message from the clinician on what is going to be the line of treatment. Okay, what would be the expenses that are involved? What are the patient's rights and the responsibilities? Then what would be the duration? That's one more thing.
Yeah.
And whom to connect to whenever there is any kind of a clarification that is required. So a person should be attending, or should be able, one person at least in a day should come and ask the patient or the patient relative, explain to the patient relative. Means these are the things I would expect as a patient in any organization.
Good. Very true. Very true. Yes, Dr. Hemant, please.
Ma'am, another aspect which have come to my mind is
Sure.
the patient is in a kind of a suffering. It may be small or a critical part of it, and his expectations are also that accordingly. For example, a person goes with a common cold to a setup, so he will be more considerate. He can wait on more, and he won't be. A person with a head injury or a shock or a trauma will go, and every minute, every second, him and his family members will count. And that time, the attitude and the proactiveness shown by, or the other factors, will be very, very important in that aspect. So it depends upon the criticality. If it's a terminal patient, everyone has told you, okay, the chances are very less. So he goes, if he goes something out of it, more kind of a life, he will be more than happy. And in those diagnosis also plays a great role in the patient's expectation.
Completely agreed. Wonderful. Dr. Samira, anything you wish to add?
Thank you so much. My net is not stable, so I didn't hear what you say. Maybe I am repeating. Sorry. It's very important to update the patient about what's going on, what happened, what are the risk of complication, or what's going on inside when the relatives are outside, especially in labor room, in emergency cases. So they expect that they will be informed. But actually, this usually not happen.
Not happen. I think
Thank
you're
you
very
so
right.
much.
Yeah. Poonam, anything you wish to add to this? Unmute. Poonam, unmute your device. Yeah. Yeah.
First of all, very good evening to all of you. Recently joined 5 minutes back. I was stuck in a traffic, so I'm trying to recollect what all you have said. I'm hearing to other people, so I'll comment later on.
Sure, perfectly all right. Perfectly all right. Isha, anything that you wish to say?
Ma'am, if I say in my context in psychology, when patients come to me, it's just that they expect within few session they should be all right and everything, and I assure them whatever they are experiencing, they'll be all right. So in my terms in psychology, this is what happens.
Can you come again?
In psychology, what they expect, we assure them whatever they're experiencing, they'll be all right within few session, maybe within few days. So this is what they expect, and I assure them that whatever has happened is not a mental illness or a mental problem. So they do not come under any stigma. So this is what, in my OPD, what I experience.
That means with every set of, patients, you would have a different set of expectations.
Yes. Yes.
And do we honestly care for their expectations? We're talking about very big things in terms of, when we say that if they are critical, they want like this, or if they are not critical, they want like this. I completely understand. Obviously, a patient's or the person's mindset would be very different depending upon how serious the condition is. But there are so many small expectations that are there, but we just don't acknowledge. We don't realize. We don't, you know, we don't care. Honestly, we don't care. Poonam, you want to say something?
Yeah, like in my setup, I deal with adolescent children, and they need privacy, which is very small thing, small expectation by the students.
Yeah.
And we sometimes forget this, and we talk in front of other children, but they don't come up with their problem. Privacy for them as a person is very important. So even smaller expectations by people, we sometimes ignore it, or we don't understand their importance of it.
So true. So true. So when the patient comes into any hospital's casualty, so this case where what Poonam is talking about is a child who is normal, healthy, but has something to discuss with the your healthcare provider, but they want some space, some psychological safety, some privacy where they can talk about themselves. Because even telling about, I feel I'm putting on weight, or I think I'm not gaining weight, is a very big thing for them to talk with the healthcare provider in presence of others. So if we look at it from the hospital point of view, patients who would come to an emergency, what is their expectation? What do you think is their expectation?
Immediate attention.
Like Dr. Heyman said, for them, every single minute counts. So they are looking at our behavior, they are looking at our attitude, they are looking at the promptness with which we attend to them, and everything has a meaning to them. Once they are little better, then their expectation will be very different. So their expectations are usually very varying. It's not static. It's very, very varying. And as healthcare providers, we need to be vigilant about these expectations of the patient and see whatever is possible that should be done to enhance your patient's experience. Because nobody comes to a hospital happily or willingly. But when they come, sorry, you want to say something, Januka?
Yeah. Just wanted to add, sometimes it's also the patient attender's expectations. Patient सोता रहता है, I mean, he's on, medicine, sedative or whatever it is. It's the attender who says, complains, TV ठीक नहीं है, AC is not working, the infra and the diet and the food and all, which adds on to the, or the billing thing which has not been told, or the insurance part which has not been covered. Like that irritates more the whole situation.
So somewhere, first of all, I think the clarity that when we say patient, it is not just the patient, it is patient and the family. We have to have that clarity so that we know when the patient attendant is living with the patient, so some of his or her needs have to be looked after by us. So therefore, corporate hospitals are preferred over government hospital because most of the planning of the corporate hospital is done keeping in mind both the patient and the family. So if I remember, around 35 years ago, I had gone to Escorts Hospital to visit a family, a relative of mine who was admitted there for a cardiac condition. And looking at the hospital, I was surprised. And the first thing that I said, is it a hospital or a hotel? So at that time, we didn't have very many hospitals like this. But I think now most of the hospitals, would have coffee shop or food court or waiting lounge or TV area or gaming area, so that the family also is looked after. And there's nothing wrong. There's nothing wrong if you can provide those services. There's nothing wrong about it. But coming back to the expectations of the family in terms of care of the patient, I think that's a very sensitive area, and we really need to be vigilant about it. And we need to be aware that if there's a need, then how can I fulfill that need and make the patient stay comfortable and enhance their experience. Dr. Hemant, you wanted to say something. You rose your hand. Yeah.
Yes, ma'am. The most important part is, ma'am, it is again, it has to be different stage wise. When we say in clinical setup, what are the expectations? So we should have a stage wise understanding what goes into a patient, a family see when they enter into a clinical setup. So initially the patient will not worry about I call it as a fringe things, like his ambient room and the channels and nurse coming with a smile and that kind of a thing, staff. But initially, the first when he comes into condition, first thing will be the treatment part of it. Initially, we will look into it, whether the emergency doctor get up from his seat or not, whether the nurses came and took vitals immediately or not.
Yeah.
And when he will be, the next expectation will be how fast he is shifted to his, and that will be priority. Third, the medication he gets comfortable. And when the patient is out of that worry zone, then his things will come, the diet part, the
Comfort
other part,
and the TV and toilet
TV and
toilet
and other. But till the time he's into pain, other things doesn't come into the treatment, the relief. How can you come to normalcy of the thing? And then he becomes normal. Then we should concentrate on other things. So this is how things.
Wonderful. So two things that we infer from what Dr. Hemant has said. If you have read Maslow's theory of motivation, have you all read Maslow's theory of motivation? So a lot of Maslow's theory is applicable to the patient expectation. If the life is in danger, and if his basic needs like air or water requirement or ventilation are at risk, so naturally his first expectation would be, get me well. At least bring me to a state where I can live my life. That's one of the basic needs. Then is safety need, where the patient wants to be safe from any kind of danger. If you can ensure medication, if you can provide me IV fluid so that my body fluid balance becomes corrected. And then would come the social need and self-esteem need and other needs. That's one understanding I have from what Dr. Hemant says. Second is, just 1 second. Second is, when the patient is expecting something like this, I choose whether I get angry or I understand. That's the choice we make. And that's very much in our hands. Do I get angry or do I understand that, yes, food is an important, requirement. Clean toilet is a very important requirement. Clean bed sheet and surrounding is a very important requirement. So all these may sound very, trivial to us. But if we look at it from the patient's point of view, you will find patients who cannot lie on any other bed or sheet because they're so used to their own comfort and they are not able to actually close their eyes for a second. In the morning when you'll go to them and ask them, they will say, I couldn't sleep. This pillow is very big for me. Very hard. The mattress is very hard. So these are all very regular, questions or requests that you will get to hear. Before I move on, I think I would ask Dr. Santana if she has a point to make. Please go ahead.
Yes, ma'am. Actually, I wanted to present it up in a way that first it is survival, then comes safety, then comes social, then comes comfort, and the last comes as unreasonable demands. So it's a series of events that take place. So this was there in my mind, ma'am.
You have modified Maslow's. Okay, wonderful. So did you all get a chance to read those few pages that I had asked you to read before we sit today? No? Have not read it?
I'm extremely sorry, ma'am.
5 case study. Sorry.
Yeah. I have given around 4 to 5 case studies in the background material that I've shared with you. The idea was that if you have a look at those cases, we will be discussing as many cases as we can do, because when you will want your audience to understand this point, they may not be this ready the way you are ready to talk about patients' expectations, the way you are contributing. They may even tell you, right on your face, man or sir, their expectations are very unrealistic. They are just not understanding. They think I'm paying, so I want everything. That's how they are going to, talk to you. So sometimes you don't want to address the topic directly, but when you take them through a journey, they are able to understand, empathize, and also reflect. What am I doing? So just a short example, and then I'll share the screen with you and we'll have a look at the cases directly. So yesterday, 3 days, as I said, I was at RML hospital for an assessment. So I just called a couple of doctors and nurses, in group to talk to them. And I asked the nurses, so what is your patient experience? What do you think about your this thing? So one of them said, ma'am, they have very high expectations. They want instant treatment. In such a heavy OPD or heavy emergency, how can we give all that, attention and care to them? And then I asked her, I said, what do we mean by prompt attention or, attending to them? She said, it is the doctor who is supposed to be attending to the patient. And I just asked him to sit and wait till the doctor comes. What can I do? That was her, in a very rude way, she was saying this. I just asked her, I said, I understand maybe the doctor is busy with another patient. If we just make the patient sit and say, I've informed the doctor, he's coming in 2 minutes, so please wait. That much of attention is also enough to give them this feeling that there is somebody who has at least attended to me and has told me that, okay, somebody will come and attend to you. And all those who were present, they said, yes, I think this is what every patient expects, that somebody at least should acknowledge that I am in your visual field. I can see you, you are there. So expectations are, yes, there are unrealistic expectations. We'll be talking about that. But a lot of expectations are very, very simple. We actually sometimes don't even fulfill that. So when you will be taking this session with your participants, this is a very interesting topic and very engaging topic, which you should do with, you can do it with front desk staff, we can do with nurses, we can do with doctors, we can do with anybody. So we'll just take them through a couple of case studies, let them read it, and then we'll ask a couple of questions. So I'm going to share the screen with you and share that,
Ma'am,
G.
a photo.
Oh, photo we forgot. Okay, so I'll stop sharing and we will first have a photo. Correct, I think. Thank you. So if those who can have their camera on, that will be nice. Isha, can you have your camera on? I know Beauty said she will not be able to have it on. So yeah. Oh, wow. Thank you. Thank you.
Background is not that presentable, so
Don't worry. The foreground is very nice. Background is even. Okay, thank you. Thank you. So as I said, you can share your, now pictures on the mass media that we are on your social media, that the program is already on. So that, and I got a request from Afghanistan that we want a program. So maybe sometimes, in the month of February or March, when we complete this, we may consider having another this thing, next batch of the students. So I'm just sharing the screen with you quickly so that we can, move on to discussion. Give me a second. Okay. So is it visible now? So this is case study 1. Maybe you will all have to read it quickly, because if you have not read, then we need to read it and then we'll have discussion around it. So normally to your students, you would have given a hard copy of the case background material, or otherwise, if you're not giving a hard copy of the full background material, these case studies can be printed and that can be given to them as a activity material. And just let me know when you are, you have read it. I'm sorry. Extremely sorry. Yeah.
Ma'am, can you take it ahead?
Move further. Is it okay? Should I move further? So should I keep sharing the screen, or I can stop sharing if you have made note of a couple of points that you have observed in the case study?
Yes, ma'am.
So can I stop sharing?
Yeah, you're showing us the discussion points, ma'am, or
No, discussion point we will hold. We'll
Okay.
work on. Yeah, I'm not showing you the discussion point, but I've shown you the case. I was hoping that you all will read the case study so that we'll just hold a discussion around it. So this whole thing could have been, this time could have been saved. Okay. So would anybody like to tell what is your observation in this case? Renuka?
Yes, ma'am. So Abdul is having a chest heart pain, and he's going. And the wife and the daughter take him to the ER.
Mm-hmm.
Thing is, what happens is there is no attention or communication being given there. Throughout, they're waiting every hour for something to be done, and after some point of time, the wife starts feeling like if it was really critical, then the doctor would have attended to it immediately. Maybe there's just making you wait, and that's how she this is the nurse, and the whole communication starts this thing, and then they want to go. I mean, the doc they don't get a proper reply from the doctor. The doctor is also
And there's confusion. There's
there
confusion
is
around
confusion, and
confusion around it.
yeah.
I completely agree with you.
Yeah.
So anything else that you observed, or anything what you think, could have been addressed or could have been handled? Dr. Hemant, you rose your hand first. So after that, Poonam would. Yeah, please go ahead.
Ma'am, I think in this whole scenario, whole case study, the role of the communicating nurse to the doctor was very critical. Actually, she could have acted as a facilitator, because she knew both the parts of a patient as well as the doctor side, what he was up to and what the patient was up to. So she could have been turned the whole things into very good ending and good this thing. Rather than not presenting it that way, so that it was not comfortable for the doctor as well as for the patient as well, ma'am. This is how.
So normally we say nurse is supposed to be advocate of the patient. She's supposed to be liaising between the doctor and the patient. But unknowingly, the role that she played was that she went and kind of instigated the doctor by, using the right way of, wrong way of, explaining what the patient wanted. She didn't have that intention. The patient didn't have that intention. But how it was communicated was that she's bored here and she wants to go out, and that's why, they want to go. So there was a complete miscommunication, and the doctor got very furious and, spoke rudely to the patient's wife or anything else that you observed. Yeah, Dr. Samira, please.
Thank you. Although the doctor did his job very well, he checked the patient, he take the blood pressure, he become sure that he is not in very dangerous condition. But because he didn't mention anything to the family, and they didn't appreciate that job, so this made him to feel not satisfied with his job, although he did well. But because there is no communication, this problem happened.
So a lot of time what happens, we assume management of the patient is our prerogative, and patient and the family has nothing to do, and they need not be even informed what is being done. A lot of time in emergency, this kind of confusion leads to allegation that the patient was not looked after. We do everything for the patient, but we do not update the family about the patient's condition. Here, at least the wife and the daughter was with the patient. But for example, if they were waiting outside, and if they were not communicated that what has been done, or what is the situation, or what is the plan of action, they would assume that nothing has been done, and the patient is lying alone and there's nobody to look after the patient. And you hear this complaint a lot of time from the family members, that nobody was attending. Wow. And Dr. Beauty says that, and this has an impact on billing as well. Very true. Because whatever you have done, if you don't inform them, if you don't update them, for them, it's not done. It's more like not done. So definitely that would have impact on the billing, and also they'll fight that this wasn't done actually for us. Correct. Poonam, you rose your hand. Sorry, I missed you, and then I moved to Dr. Samira.
Almost same. Initial was an prompt attention by the doctor and the nurse also for the patient. Once the patient was stabilized, he was not explained properly what is your condition, and the family members were also not explained about the condition of the patient, so that they were comfortable at the initial first step was good as per the case study. Later on, there
was no communication.
No communication. Lack of communication, gap in communication was major factor in this case study.
And don't you see something like this every day in the hospital?
Yeah, every day in the government hospital, even private hospitals. This is such a small things we miss, like communicating, like informing, updating about the condition of the patient, which is really very important for the patient and the family.
So the expectation of the family was, or the patient was, that once you have examined, first of all, tell us what is the status. Is it heart attack? The worry itself is very bothering. Even if you're not sure, and if you say, it doesn't look like, but let us get the ECG done, I'll be able to tell you only after the ECG. Or even if you have done the ECG and you say, there are not major changes, we want to observe the patient. We don't want to send the patient back. We need to keep the patient for next 24 hours and observe the patient so that there are not major, health concerns. So today, patients want to become part of care management. They want to know what is being done. They even want to know what are the options available. We can't admit the patient and say we have admitted and this is what we are going to do. So we got to really tell them what are the options available or what we are planning to do. Patient has right to refuse. So yes, yes, Dr. Hemant, yeah.
Ma'am, at times what happens, see how the health system is managed. So that is also important. Like whenever we are seeing a case and you see the case and you move on to the next patient. For you, the 15 minutes is a normal thing.
Yeah.
And the course of the action, like disposing the patient.
Yeah.
So if you want to admit, and if you could say, okay, the case will need admission and they will look after other patients, that would have been fine waiting for them to say.
Yeah.
Or we'll observe you for half an hour and then you can go. So closure of the case is also very important. And if the doctor has to attend, he can say to the team, okay, explain the closure, what actually we are planning.
Yeah.
And without asking by the patient in Indian healthcare scenario, there will be very rarely doctor who will say this thing had this complaint and we have managed with this and now we can. It's generally when you ask doctor what happened and why this thing, then he said, okay, it was a mild abdomen. So that kind of a
that also in the minimum possible words. That also in minimum possible words. So I remember my brother was admitted at Max Hospital, and in the morning round, the doctor said discharge. So once they say discharge, no, not discharge, move to ward. From ICU, move to ward. So we thought they're going to move. So we kept waiting. It was 12 o'clock, then 1 o'clock, then lunch, then post-lunch, then evening tea. So around 5 or 6, when I went to the hospital and I asked, haven't they moved him to the ward? They said, no, not yet. So I went and spoke to the resident who was on duty. I said, in the morning round, the consultant had said that we move the patient to the ward, but why haven't you moved him to the room, and why is he still here? So he said, I don't think he said so. I said, no, he said this to us very clearly. The staff said, yes, he said, but we have not entered in the system. Now, imagine. And if you have not entered, then the patient is going to be charged for the ICU. Imagine the patient's flight. The patient is there for good 4-5 days. Already they have spent 2-3 lakh rupees for those 5-6 days. For them, every penny matters. So sometimes these small lapses on our side also upset the family. And then what they won't assume it as a lapse. They will assume that it's a deliberate act of omission. That you did this because you want to cheat me, or you want to charge me, or you want to have another 1 day's, ICU charges from me. So that's how the whole communication breaks down. Also, when the patients and their family expect us to, attend to the patient, like you said, when they come in critical condition, they expect us to attend to the patient. Simultaneously, how many of us really address the family? A lot of time, confusion happens when the patient is inside and the family is outside. You are managing the patient very well, but you're not attending to the family, thinking that's not important. Important is this patient. Agreed. But can't we have people who can manage both the things? So I was interacting with the CMO of All India Medical Institute, AIMS, Delhi. So I asked, he was CMO for good 5 years. So in a very lighter vein, I asked how many times you had fight with the patient's attendants, because I know it's very often that we have aggressive, reaction coming from the patient's family. He said, not even once. Not even once. I was surprised. I said, how come? He said, every time any patient came in critical condition and my team started working on the patient, I would personally go and meet the family and talk to them and explain them and prognosticate that this is the condition, this is what we are doing, this is what we are waiting for, and whatever changes happen, I will let you know as things change. And that's the proper protocol. lot of aggressive reactions can be prevented just by regularly updating the family about the patient's condition. Now, in this case, what we are seeing here, it's just nothing. It's a simple case for us. But a patient who has come out of fear for MI, look at their state of mind. The daughter is crying. The wife is worried. What are they looking for? Somebody to tell them it is heart attack, or no, don't worry, it is not heart attack. Imagine the confusion. And we are not clarifying. And even if we are not clear, can we at least tell them that we are yet not sure? We are waiting for the ECG to be done, or we are waiting for another investigation to be done. So understanding the expectations of the family is equally important. And addressing them to time is very important. So what else did you observe in this case study? Gurleen, anything you wish to add to this? Do you remember the case study, finer details?
Yes.
And you saw, yeah. Oh, you have a printout. That's good. That's so good. That's so good.
I think pretty much, I'm just gonna summarize what everyone said. Ma'am, I do feel that the doctor started it really well, but he should have, before exiting the room, if he wasn't able to speak, he could have asked the nurse to reassure the family and the patient, and that would have prevented the situation.
So even simple communication like this, that, okay, we need to observe him for a couple of hours. I mean, how much time would have it taken? Not more than, I think, a minute. Even if the family asked a couple of questions, it wouldn't have taken more than 2-3 minutes. Just yesterday, Rajiv Gandhi Cancer Institute's, very senior doctor, she was sharing the feedback of her hospital. So one of the patient had given this feedback that I paid 1,500 for the consultation, and the doctor shot me out within a minute. It was less than a minute. Imagine, how would the patient feel that I'm paying you and you're not even ready to talk to me and listen to me and explain to me and answer my questions? And if they tell us that you are just there to make money, tell me, how are we wrong? How are they wrong? We need to at least justify their visit. A lot of time, consultants will go to the room and just ask in a very casual tone, "Theek ho? Sab theek hai? Koi dikkat to nahi hai?" and move out. And consultants visit added. How would you justify that? Nobody has additional fund kept for their medical care. Nobody has reserved 10 lakh, 20 lakh rupees. Okay, if I fall sick, I can use this money. Do we have? Any one of you? Except some of you who will have their medical covered by insurance company. Otherwise, so when you're paying for medical facilities, you're paying through your nose. And at least that value for money has to be given. And just flying visit, okay, how are you? I hope you're all right. So, theek hai, koi dikkat to nahi hai, khana khaya, dawai li. I mean, that's not the way you talk to your patient. Sorry, Dr. Santana, I'll come to you. Dr. Hemant wanted to say something. Yeah, Dr. Hemant, you wanted to say something?
Yes, ma'am, which initially I added, the moment you go inside, deliberately you know that this patient doesn't, it's a routine case. You have seen thousands of cases like that.
Yeah.
And you know, for it is a routine knee pain.
Yeah.
But to talk to him, yes, this raised thing, and you are this thing, and to give him at least 5 minutes, ma'am, it generally also has to do with the time of waiting period. This is also one of the things which I have felt.
Yeah.
The person's waiting period is more.
Yeah.
Say 1 hour, 2 hour, 1 day, or
Yeah.
you have got an appointment 1 month back. There are doctors
Yeah.
who are getting 1 month, 3 months back, ma'am. I am confident. So in that scenario, few are just going in and coming out. So that's
how disheartening that can be.
Disheartening.
I completely.
And ma'am, I want to share this with my esteemed members because that in Indian Spinal Injury Center a few years back. I went with my mother-in-law and the orthopedics head of the institute. So, and he had a waiting period of 3 months. So when we got our chance at 12 in night, 12 in night, Dr. H.S. Chabra, I remember and I always say. So Dr. Chabra's call we got at 12 in night after waiting for that. And after initial examination, and when he came and entered, his body language was such in the way, the confidence level of his and how he interacted, that we felt that it is 10 in the morning and he has been working throughout the day. And the way he managed things. So that kind of thing, he understood. He gave us 10 minutes at 12 in night. So that is how we remember, ma'am.
Yeah. See, you remember two things always: what went well and what went wrong. These two things we always remember. In between, we forget. Dr. Santana, you wanted to add something.
Ma'am, I'm adding my personal experience that when I had COVID and I was admitted in a hospital, I was there for 9 days. Okay. And when I was in ICU, okay, fine, there was the RMO. But when I was shifted to a private room, and which was a single room, I was being charged for a doctor who's supposed to come twice in a day, the consultant. I was being charged 1,200. And for the houseband, 800 rupees. And for 4 days, only once the houseman came. So if I would say 4 into 2 is 8. So instead of 8, there were only 1 visit, and 7 visits were charged to me for no reason. And when I had put this up, and actually I made an issue out of it, that I don't mind paying money, but please don't say that this is consultant's charge, because I have not seen the consultant for the last 4 days. So I was told that no, the nurse was giving him the information. And I said, you are telling it to me. At least don't tell it to me, because I know how the healthcare industry works. I'm sorry, I should not use the word industry, how the system works. And you can tell this to the other patients, but not to me. Means I had a meeting with the board, the entire board of directors, and I told them that this is just not acceptable. And on the other hand, just like you said, the positive thing that you remember, that when I had my second child and it was an LSCS, because there were a lot of complications, this doctor who had gone to Pune was called immediately. He had gone for a family function, but he said, no, if she's going to deliver, like, since it was like known people, they said that I'll come personally. And he came down immediately and operated on my son. And at the same time, till the time I was out of the ICU, the doctor was attending me 4 times in a day, just coming and asking, how are you feeling? How are the vitals? And other than him, even his RMOs were coming and asking. So I still remember those good days, like, no, though it would not reduce my pain, but at least it reduced my anxiety.
And tell me, how are these expectations wrong? Tell me.
I beg your pardon, ma'am?
I said, how are these expectations wrong? What you're sharing, the experience that all of you are sharing, is absolutely very genuine expectation that any patient would have. But how far are we really understanding and, attending to this? See, if you also saw that, just 1 second, Renuka, the nurse came in 2-3 times and went out. She must have seen the monitor. She must have seen, okay, the cardiac line is fine, the respiration rate is fine, the pulse is fine, the BP is fine. But what about this?
Exactly.
It was done more mechanically than in any meaningful way. So, Renuka, you wanted to say something?
Yeah, ma'am. Renuka ji, 1 minute. And just to tell you that in both the cases, the doctors, the entire fraternity were very well known to me. They were like family friends. So look at the difference. And the number 1, which is a good experience, was in a government hospital, was in a railway hospital. And number 2, which is a bad experience, is in a private hospital, whereas it actually should have been the other way around.
Yeah.
So there are difference of the working styles, ma'am. And this is what actually all of us are now working towards improving, ma'am. That's the reason why we all are together today.
So true. So Renuka, you wanted to add something?
Yeah. This is a case point with my parents and in-laws. My in-law stays with me and my mom is in Bangalore. My mom is a central government servant and she always goes only to CGHS. And my father-in-law here, geriatrician, we have our geriatricians, he goes. But the case here, doctors are, I don't know, the thing, what they always tell me, whenever they go in for a consultation, whether it was CGHS or to a private doctor here, they always have this grouse. We go there, this thing, but the doctor didn't even touch me, didn't even check me. Like, you know, they are not even. He has this thing, no, my father, no, he didn't even check my pulse.
Well,
Even
very often they say they
listen,
didn't.
I don't know
See the
whether it is a
expectation.
time constraint.
What is
Yeah,
more, Dr.
Huh.
Devi Shetty has actually done beautiful videos on the importance of touch.
Oh.
Dr. Samira, I don't know if you know about Dr. Devi Shetty.
Uh-huh.
He's a cardiothoracic surgeon in India. Actually, he was practicing in UK. He was in NHS, and from there he came down to India. In NHS, he was called operating machine. I mean, that was the level of surgeries he did. So he came down to India. He started to practice in India, and I mean, he would give excellent results. But he said that he did not initially made any effort to build rapport with the patient. He has written this in that book, that Communication, Cure and Cure. But after he changed his way of handling the patient, rest is history. Like, he's known so well for his work. So quickly to conclude of this case study, so that we can move on to the second one. Maybe we'll have to cover only 2 this time, and we'll see how we can cover some more case studies. Quickly to conclude, what all could have been done to prevent this communication, failure or gap or misunderstanding right from the beginning? Gurleen.
Ma'am, to begin with, I think empathy would have helped.
Okay.
And reassurance when the nurse.
Okay.
Yes.
Reassurance of not the outcome, but
yes.
we are doing our best. We shall do our best.
Yes.
Okay.
Explanation by the doctor when he wanted to monitor the patient. I think right at the beginning, if you could explain to the patient. And
Correct. Beauty, do you want to add anything to it?
Ma'am, I think most of the points are covered. Just the information that was not given.
Yeah.
Probably introduction. I don't know, that piece is not mentioned. If the team was introduced and if the family was introduced.
We are not sure. So, we are not sure.
So we are not sure. If at all that was not, then that should have been something. And then the entire care plan, like what is the beginning, what is the end point?
Inform.
Like information.
Updating them, informing them. The plan of action should have been shared and negotiated with the family and explained to them. And what about the apprehension that the family had?
Yeah, I was about to say that each one had a different way of reacting. The daughter was very emotional. She was, in a hyper state, whereas the wife was trying to take stock and being more in control. At least that assurance, one line from their side. Okay, you just have to wait, but he'll be all right. So that's all a lot of.
Exactly. And then also the communication sometimes that we make about the patient with another person, that can completely alter the quality of communication between us and the patient. The way nurse went and communicated about the patient, I think that should tell us that we need to be very careful when we are talking about somebody. And we have to make sure that we don't add any additional fuel to the already hot situation. And one second, sir, one second. So the person has to, we all have to be very careful when we are talking to the patient or about the patient or communicating their message to the other person, that we don't change the intent and the message. And you see, at the end, ultimately became so, frustrating for everybody. The doctor was unhappy, the patient was unhappy, the family was unhappy. So we have to be very careful in making communication in a very, very responsible way. Yeah, Dr. Hemant, you wanted to add something?
Ma'am, I just wanted to add the reason why at times we witness this. So most of the time it happens we and us. So they and us. So the patient becomes an outside party, and we all become same. Together. So this again creates that kind of a thing, and the doctor again without knowing.
Obviously we fight, and there'll always be. So Dr. Samira, how is it in your country? Like, do you often see similar situation, or it is different?
Exactly same, if not more worse.
Oh my goodness. So we are all alike.
Yes.
We are all alike. And one more thing that I observed, even if the nurse came and said all that in that manner, even the doctor could have acted responsible. Overreacting to this was also not a very justified kind of a behavior. I think one learning from this is that even if somebody comes and tells you something, that is, that upsets you, but we got to be responsible when we are reacting to this situation, and also need to get first-hand information before we come to this conclusion that the family is bored of sitting here and they want to go back. So even his, being, aggressive and using a foul language for the family is not justified in this situation. Beauty has mentioned that there was lack of empathy. Yeah, I completely agree. Actually, the word empathy sometimes becomes so meaningless in a situation where we are working so mechanically, that if we talk about empathy, it sounds like something that we are asking, which is just out of this world. What do we mean by empathy and what empathy? We are doing our job. I clearly remember I was taking a session for postgraduate students, and one of them asked me, "Ma'am, why are doctors expected to have empathy for the patient? Why can't we treat it like engineers or chartered accountants and any other professional? Why are we expected to have, empathy for the patient?" Trust me, for a couple of seconds, I was speechless. I didn't know how to. I mean, that was something it's something like you're saying, why are doctors expected to know medicine? So then, of course, I gathered my, thought process, and I talked to her. I said, see, you're handling patients and they are unwell. They are human beings and they are upset. So if you are not empathetic, you will not be able to give them holistic treatment. So you need to understand what is their, mindset and what they're going through. But for a second, even I was sick. So a lot of time, even in your, younger generation, you will get to see that many of them take medicine, nursing, pharmacy, and others, paramedical subjects, just because they are paying branches or they are paying professions. They are not taking it up for the reason of compassion or service. I mean, that element is completely now getting lost in the in with time, and that's the challenge why we are having, people who are working so mechanically. So I hope exercise like this would sensitize them. What do you say? Like the one we have done just now, taking them through the journey of the patient.
Yes.
It would help them reflect. And a lot of them must be actually doing something similar to it. Isn't it? So should we have a look at the second case? Okay, we can have, quickly the discussion point so that we haven't missed anything. First point is, should the Rahman family have known that Abdul was continuing to be monitored? And how might they have known? I think, yes, we all are agreeing that, yes, they should have known and somebody should have informed. Whether the doctor on duty who examined the patient, who settled the patient, before leaving the patient, he should have talked to the patient or the family member and should have informed about the condition. Second is, how did the expectations of Rahman family change during their visit to the emergency room? This is interesting. So if you could see, the first expectation was, somebody please attend, somebody please see if the patient is all right, if it's not something very serious, and then later on, please let us know what is being done or what is going to be done in the time to come. And how did the behavior of physician and nurses affect this change in expectation? How did that affect? There were
a lot of unpleasantness in them and disappointment.
Disappointment. Very true. Yeah. And we have discussed this. How could this be avoided? We have discussed at length. So let me quickly share the second case with you. Okay. Give me a second. So Gurleen, good that you got that printout. You got the whole set printout, or you have?
Whole set.
Yeah. So I think I would request all of you to take a printout. Rather, I normally do a spiral binding of whatever I I just share with you. So this is the document Dr. Samira would know. We received from ACH. So I normally, if I get something like this, I don't leave it to laptop. I would always have a copy of it and have spiral binding done. So if you have it, then it is easy to go through and flip through it, and then also underline, and because we come from the era of pen and paper. So we can't, we are not happy if you're not able to write or scribble something on the. So let me quickly share the screen with you and let's have a look at the second case. This is also again a very interesting case to look at. Okay. So yeah, you can read it and let me know when you have read, I'll move it further.
Done, ma'am. We can move.
Okay.
Done.
I'll move further.
Ma'am, I read it from the download.
Oh. So should I move a little further or it is okay? No, I think till this you have read. I'll keep it. Yeah. Yeah, maybe you can download in your phone and you can read it if that's possible.
Done.
Okay. So I stop sharing. Everybody, please tell me. Or you want a little more time? Should I stop sharing? Why is not anybody responding?
Because we were mute.
We just nodded, ma'am.
We nodded.
I don't see anybody because I was on the screen share. It had I was looking at the screen share. Okay.
Yes, ma'am.
So this is a very, very interesting case. So what is special in this case?
I think, first of all, having a child itself is a very special moment for every parent and every family.
Very true.
That, to start with, I think that is a very special point.
Very true. I think most important here was one that they were having a child. They were having a child almost like after waiting for 5 years. So that becomes their precious baby. And then 9 months of pregnancy, I think any one of us who have gone through it would know every minute passes with a lot of apprehension, worrying, concern, doubts, so many things. Yeah, Dr. Hemant, you wanted to say something.
Yes, ma'am. I just wanted to add, because when it's a case of fertility issues,
Yeah.
so and the success ratios are very less, and it becomes very apprehensive.
Yeah.
So those anxieties are much more than a normal labor.
Exactly.
So,
Exactly.
yes,
And not only if you have conceived, after a long wait of 5 years, trust me, anybody going for labor, the family's major concern is that both baby and the mother should come out safe. That's their major concern. And I have 2-3 examples to share with you to help you understand how emotions are so high in labor room, and how, unfortunately, we have had to come up with something like respectful maternity care. That's because in the labor room, sometimes we are so callous with the patient, so rude with the patient. I have seen, doctors and nurses literally hitting the patient. जोर लगा, जोर लगा, जोर लगा, जोर लगा. And also ridiculing. अब दर्द हो रहा है, तब दर्द नहीं हो रहा था. I've seen this. I've heard it myself. So imagine the plight of the mother. And just 2-3 days ago, I was reading, I don't know, sometimes, on the phone, sometimes you have some proper. So that it said, in all other surgical cases, we give rest to the mother. We give rest to the patient. For example, if anybody undergoes, any surgery, appendectomy or anything, so we give rest to the patient. Okay, for next 1 week or 10 days, you be on bed, we'll provide you everything. She said, I underwent LSCS. And the very next day, my nurse brought the baby and she handed over to me. You must learn to look after your child. That was really thought provoking. I never thought it from that point of view. Where is her share of rest? Then in another case, in one of the hospital, the lady was having false labor pains. The resident saw the patient and moved on to the next patient. Mother-in-law of the patient felt that the patient is not being looked after. And she suddenly started having this fear that we will either lose the mother or the baby. She went out and she told to her son that they are not looking after. And we might lose the mother or the baby. या तो बच्चा मर जाएगा या माँ मर जाएगी. कुछ नहीं कर रहे, देख नहीं रहे हैं. That man was a he-man. He came in, started fighting with the residents, literally tore clothes of one of the residents, slapped her. And what was the reason? She did not communicate that she's having false labor pains. We don't have to do much. We have just kept her under observation. And most likely these pains will subside because they are not labor pains. That's all. Do you see this in your country, Dr. Samira?
Yes, yes, commonly, daily.
Oh my goodness. And is it difficult to communicate this? How much time will it take? Again, somewhere we think patient management is our prerogative. We don't have to involve the family. They want to know. They want to be involved. They want to be told. And is that an unrealistic expectation? And very often you will see the lady is inside, the husband is outside. It's a female ward, female labor room, so no men are allowed. In another hospital, one of the gynec, she shared her experience. She said, in our hospital, we had a schizophrenic mother. She delivered a male healthy child, perfectly fine. And she said during the labor, we allowed her husband to be around because we thought we will not be able to manage on our own. So we allowed the husband to be with the patient, and we really, managed it very well. She delivered normal, healthy child. Now in the ward, we don't allow male patients to stay, male attendants to stay. So the husband was asked to stay outside, and the lady was allowed to have a female attendant inside. At night, the mother breastfed the baby, took her medicine, and she went off to sleep. Around 3 or 4 o'clock, either the patient or the attendant, they saw the child wasn't breathing and child had turned blue. So they immediately went and called the resident, and this resident who was sharing this whole case, she said, I was in the labor room and incidentally I was on duty at that time. I came and saw the child. I picked the child. I rushed to ICU to resuscitate the child. We went to, NICU, neonatal ICU, and we tried to resuscitate the child, but we knew we will not be able to do much because the child had already gone. She said, when I came out and when I told the family, her husband, who was such a gentleman, was so well behaved throughout the labor, throughout the, complete interaction. He became completely insane. He started hitting everybody. He started breaking things. He started abusing people. Because something like this can derail anybody's wise man. So places like labor room, OT, ICU, they're all very, high emotion areas. And if we don't understand the family's expectation and their, mindset, or what they're going through, or their apprehension, there can be violence against us. So in this case, what do you think was completely failing? The case that we have read just now. Yes, Atan, please.
Ma'am, number one is I feel like at any moment of which I have, with my personal observation, I'm telling you whatever my experience is, that the gynecologist or the attending obstetrician should not keep all these things, informations pending for the last moment. The patient regularly visits, and with every visit, she should take it one step ahead on what could be the circumstances that the mother could face in the coming months or in the coming weeks. And even before her delivery, since she was in the 9th month of delivery, and she would have definitely gone over there, since they are from the army background, that's what is being mentioned, so they must have gone. So the doctor should have very clearly made both the parents understand that these are the set of events that can take place. These are some consequences, or these are some situations which may take place, in which we would be acting accordingly. Okay, so once they would have been mentally prepared for it, here everything is like he doesn't know anything, because he's never been told about meconium. He's never been told about that there can be an LSCS, or that there is a baby in distress. Such situations can take place. So if the doctor explains all these things well in advance, the patient and the patient's family is prepared mentally for any of the untoward incidences that take place, or if the patient is going to go in for future treatment.
Yeah. True.
Correct. That is one point amongst the various points. Then my colleagues can discuss.
Good observation. Any other observation? Anybody? Yes, Dr. Hemant. Yeah.
I always feel, ma'am, the treating consultant is at the center point. So he should or she should take the onus of the cases which are into a long treatment line of like labor cases and such. And it is their prime responsibility to let the hospital know generally whenever their case comes. So and they instruct the nurses of the labor area and the matron to take care of that patient, because they know the specificity with that patient, what can be the complication or it is normal. And once a call goes or she or he reaches, So that is sufficient. They take care of the instructions are already there, the doctor, and they take care. They take care, ma'am. That is all.
Thank you. Thank you. Any other input? Dr. Samira, any input from you? Please,
the husband was thinking about his wife as a human being, whether she is comfortable, whether she have dinner, whether she has any problem. But the healthcare professional, they miss this point. They only think how they manage the labor, how she can deliver vaginally, or if there is fetal distress or not, if there is an indication for C-section. This is the only thing that they thinking about.
The vision of focusing only on the disease and not the patient. So holistic care was missing. Care was missing. Correct. I understand. Any other point from Beauty, if you wish to say anything, if you want to add something? I have one point to share with all of you from this learning.
Ma'am, yes. In fact, ma'am, I wanted to ask a question on the example that you shared where the schizophrenic mother delivered, and so maybe that we can discuss after we are done discussing here. I just wanted to understand in the example that you shared what could have been done better. I mean, I'm thinking from the point of view of preventing such episodes.
So if we knew that the mother would be taking medicine, and we know that if she's taking, medicine that would put her to deep sleep, then the child should not have been left with the mother. Or husband could have been allowed, who could have handled the child in a better way, because his commitment to the child would have been far better than anybody else's commitment. And the example I normally, when I quote this case, I always tell them this part that I did not bring in here. This doctor said that he was hitting everybody, abusing everybody, throwing things away. He said only one person with whom he did not misbehave was, she said, it was me. And the reason she said that, because I had very cordial relationship with him when we were in labor room. I built rapport with him. I was well behaved with him. I treated him with respect and care. And that's how we had developed rapport.
Can I add?
Yeah, please. Yeah.
Ma'am, I really want to add one line which I always reiterate the staff also.
Sure.
And in life as well as in healthcare also, your good work is always for your bad times. So if you behave really good, take proper rounds and this thing, so they know you have been putting your efforts, and that day you will be able to save out the situation rather than a person who is coming abruptly that day. So your one nicety on that day will not matter. Whole commitment the moment they arrive. And
I completely agree. I think very true, very true. So one more learning from this case is, if you are the consultant and you are managing the show, you need to have your team ready to handle this case. You may not be there all the time. You may fall sick, you may have to travel, you may leave the hospital and go to another hospital. So that means it is not just one person managing one case. It should be a team of people. If you have them with you, and if they are familiar with the case, if they have seen the case, if they have all the details, I'm sure the patient also would form rapport with these residents, and they'll be able to manage the case. So it should never be one man show or one person show. It should be like team, and then probably this confusion could have been avoided. I mean, if the doctor was not there, somebody else could have definitely managed the patient, would have made the patient comfortable. Then, of course, addressing the patient's needs and the family's needs should be looked after. If we look at the husband was waiting outside, sitting outside, he was not communicated, not informed. And this is not new. Yesterday, as I said, I went to RML for 3 days. So last day, I thought I have not visited the labor room and I want to go. So I requested them, I want to visit your labor room. So I saw the labor room, looking at the size of RML. I mean, it's such a huge, huge hospital. The labor room was very small. The entry was very small. And the attendants were literally sitting on the road. And I just asked them, like, how's your patient? I mean, you don't have any place to sit. They said, it's all right. Very little expectations patients have from a government setup, because they don't expect chairs and waiting area, lounge, but the minimum expectation that at least update them, inform them, tell what you're planning, what is happening, even that's good enough. But sometimes we fail to even do this small service to the patient. So I'm stopping it here just with one this thing. Dr. Santana had mentioned unrealistic expectations. So I want to, mention that, and then we move on to the activity that Dr. Samira and Dr. Santana are expected to do today. See, patients will have unrealistic expectations. Problem is, we need to identify and address them as soon as you get to see an expectation that is not realistic. For example, if patient says, I'm paying you and my patient should recover. Is that a realistic expectation? But do we address it? So we need to help them understand. I completely understand you are paying for this service. And I know paying for a hospital is not easy. It's a lot of money that you have to pay. I wish I had some way to give you this guarantee that your patient will be perfectly, fine after the treatment. I would request you to ask me to guarantee you that whatever best needs to be done will be done in the care of the patient. But I cannot give you any guarantee for the outcome. So whenever you see unrealistic expectation, we must address, we must fine tune, we must help them see what is in our control and what is not in our control. And if you can manage that right in the beginning, you will have less problems at the end. When patients come from a smaller place to a tertiary care hospital, they expect miracles. When they come to a big hospital, they expect miracles. They think we are paying, patient should be fine. And when you are not able to help them see that money does not guarantee life, they'll get to. So these unrealistic expectations should be addressed. It should be talked about. Yes, Dr. Hemant, you wanted to add something.
Yes, ma'am. I wanted to add on this aspect. This line, at times, because an insurance cover for the physicians or the clinicians, we are in a safe zone. If the patient goes off, goes off. If it doesn't work out, because we are in a profession where there is no guarantee. So it times that it goes in other way. So we need to have that kind of accountability. Certain kind of accountability has to be remained.
I completely agree. And so some of the allegations that we hear for us and for our profession are not false. They are not untrue. We may not like it, but they are not untrue. So it's 9:30 and we move on to the last part of the session. So who would be presenting first? So please remember, you have 15 minutes time. Have your stopwatch right in front of you. I would not like to stop you in between, but 15 minutes means 15 minutes and we end the activity. So
we would have the pleasure of having Samira ji as starting this entire session for all of us.
Wonderful, excellent.
Thank you so much. So shall I start?
Sure, please. Yeah.
Okay, thank you. Today we will practice the skills of dealing with angry patient using a medium which is called role play. But at first I want to know your previous experience and your opinion regarding using role play to learn new skills. And I want everyone to answer me by using thumb up or thumb down. If he think that this is the best way for learning new skills, so please make your thumb up. If you think the opposite, make your thumb down. If you are in between, make your thumb in between. So there are different opinions. Some of them are with the using role play, some are in between, some are not. So really, many people think that because role play is not realistic and it's not it's artificial, so they think that it is useless. And but this is not true, really, because it is an evidence-based method, and is the best method for practicing new skills without the fear of harming the real patient. And also another advantage is that we can practice it, these skills, and repractice and repractice. We have no fear for of anything, because we are learning. And we other advantage is that we can get feedback from our peers, which is very, very important for learning process. So every one of you will have the opportunity to do this role play. And I want to begin with one of the participant, who is willing to do this role play at first. But I asked before the session, and Gurleen volunteered thankfully to do the role play of the care provider. So Gurleen, please, could you tell us about a scenario, a common scenario that you face it daily or commonly, which might be appropriate for practicing the skills of dealing with angry patients?
I think long waiting times. Sometimes
Yes.
long times in OPD.
Yes.
That could be a cause of frustration.
Yes. So could you please tell us more information? The patient was waiting for what? She was in outpatient, inpatient. Further information, can you please?
Sure. So the a patient who has probably taken a few hours off work has come for consultation, wants to get an abdominal pain checked out, and has been waiting for a while. The doctor is attending to a critical patient, and he's been waiting and is getting impatient by the minute.
Yes. Okay. So you was the doctor that you will receive this angry patient. And this is the first time that you saw this patient. Okay. Do you have any name? You want the patient's name to be what? Or it's not important?
Oh, it is important. Rose?
Okay. Okay, thank you so much. Anyone is willing to play the role of the patient, please? Anyone of the participant? Yes, thank you so much, Santuana. Thank you so much. Do you want further information? Do you want to ask Gurleen for further information in order to be able to play this role?
I am the dissatisfied patient who's been waiting for a very long time. So I would be acting as a patient, and please apologies well in advance if you find me like one of those irritable patients you normally see.
Thank you. Thank you so much. Gurleen, please, you have the list of the skills of dealing with angry patient in front of you. You have the list?
Yes, I
Okay.
have.
So what are your objectives? What skills do you want to practice?
First, I'd like to explore why the patient is angry. I think this could be gauged by the facial expressions, body language, tone of voice. I'd like to confirm and make sure I've got all the information. Then I'd like to apologize. It does not mean essentially that I'm in the wrong, but just to calm them down. Express empathy and find a resolution, ultimately reach a consensus so that we can get to the stage where I can take the history and get to the treatment part.
Great. Okay. So I sent a list of the skills to the group. Did you see the list? Okay. So is there any skill that you want us specifically to observe you and to give you feedback from the list of the skills? The first skill is naming the emotion, and the second is apologizing and acknowledging patient's feeling, and avoiding being defensive, and asking for the causes of anger, and so on and so on. So is there any one of these skills that you want specifically for us to observe you and give you feedback?
I think to avoid becoming defensive.
Yes, okay. Okay, thank you so much. So now I will assign the other members of the other participants. I will assign everyone for observing a specific skill. So, do you mind, Poonam, do you mind to observe the skill of naming the emotion and apologizing and acknowledging patient's feeling? Okay, thank you so much. Heyman, please, do you mind to observe avoiding being defensive and asking for the causes of the anger?
Can I get it again? Could not get
Yes,
the word.
if you don't mind, please observe if she is using the skill of avoiding being defensive, first one. And the second is if she is asking the patient about the causes of being angry. Okay, thank you so much. Beauty, please, could you observe the skill of acknowledging patient's view and attentive listening to the patient? Please, thank you so much. Rinoka, please. Do you mind if I ask you to observe whether she is asking for patient's perspective for solving the problem? This is the first skill. And we have other skills, but we have no observer. So I assign you three tasks. And also observing if she offer her view to solve the problem or not. This is the second task. The third task is whether she is thanking the patient or not. Thank you so much. Any question from anybody?
Dr. Samira, can you again tell me my skills, what I have to observe?
Yes.
Can you repeat? Yeah,
of course.
Sorry.
Whether she is naming the emotion or not, and whether she apologize and acknowledge patient's feeling or not.
Okay, thank you.
Okay,
So,
thank you so much.
We have just 5 more minutes left.
Yes. Okay. So if you are ready, Dr. Heyman and sorry, Dr. Gorlin and Dr. Santuana, you are ready? Are you comfortable? So please, you can start.
So how much time do you want to give them? Because if you
Yes.
want to display all the skills,
I
I will take 1 minute to
3
scream,
minutes.
shout, yell. I'll take 1 minute to scream, shout, yell.
No.
4 minutes, please give it to her.
Santwana, the thing is, the major learning is for Gurleen to learn. That's one thing. What I would recommend, if we get into the role play, it's going to take you at least 5 minutes for the role play and then at least 15 minutes for the feedback that you will take from everybody. For the timing, either we skip Santwana's activity and we continue with this, because this is the first time we are doing, so we need to have more clarity on how we have to utilize the time and what has to be the outline of the program so that you are able to actually do.
I have a suggestion.
Yeah.
We can add other 15 minutes today to our session.
I am okay if everybody is okay.
Okay.
So Dr. Santwana, you will be able to cover in 15 minutes? Because I'm very particular time.
Ma'am, yes, ma'am. Would you allow me to present the PPT?
Total 15 minutes where you can do whatever you want.
Okay.
But stick to the timeline.
Yes, ma'am.
Okay. role play is a very important activity that we do in any program. So it's a good learning, and Dr. Samira is bringing all her learning from ACH. So you are getting to learn, the right way of conducting or facilitating a role play. So make note of these steps. You can even take more help from her to understand how do you go about facilitating a role play. It's a wonderful learning. So Dr. Samira, please go ahead. Yeah.
Oh, okay. So please, everyone, we will turn off our video, except Gurleen and Santwana, please, during the role play. And at the end of the role play, at the end of 3 minutes, I will turn on my video. This means that the time is off. Thank you so much. Dr. Heyman, please, can you turn off your video, Dr. Heyman? Okay.
Shall we begin?
Yes.
Can we start?
Yes.
Hi, Rose.
ये हॉस्पिटल है कि क्या है? यहाँ पे पिछले आधे घंटे से मैं रुकी हुई हूँ, यहाँ पे कोई बताने वाला नहीं है. मेरा नंबर आकर के चला गया, मैं यहाँ बैठी हुई हूँ. मैडम, आपके हॉस्पिटल में होता क्या है? ये तरीका आप लोग का पेशेंट के साथ में? मेरी बूढ़ी माँ कब से यहाँ पे बैठी हुई है, हम लोग को कब समय दोगे आप लोग? आपका बंदे ने मुझे बोला, आप मेरी बात सुनिए पहले, आप मेरी बात सुनिए. आपका बंदा जो है इधर ये बैठा है, ये बैठ करके अभी थोड़ी देर पहले यहाँ पे ऐसे ऐसे करके तंबाकू खा रहा था. ये सब आप लोग को टाइम है यहाँ पे करने के लिए? हम जैसे पेशेंट यहाँ पे पैसे देके आते हैं, आप लोग के पास टाइम नहीं है? हम यहाँ पे कितना देर रुकेंगे? मैं मेरे बच्चों को घर पे छोड़ करके आई हूँ, वो स्कूल से आने वाला, वो स्कूल में बैठा हुआ है. मैडम, हमारा कौन देखेगा? हम लोग यहाँ पे मेहनत करके आते हैं, पैसा हमारी मेहनत का है. आप लोग को क्या है? आप लोग को कमाने में 2 मिनट लगते हैं, आप लोग कोई पूछते भी नहीं हो हमको. मेरी माँ को कौन संभालेगा यहाँ पे? आपके बंदे को समझा दो, मेरा समय पहले आया था, इसके पहचान वाले को इसने अंदर कैसे भेजा? ये तरीके से काम नहीं होता है मैडम. मैं यहाँ पे हंगामा करवा दूंगी, आप जानते नहीं हो मेरे को, मेरे बहुत बहुत पहचान है. यहाँ पे गुंडे आ जाएंगे, आपका हॉस्पिटल तोड़ देंगे.
I'm really sorry, ma'am.
मैडम, ये सब इंग्लिश में मेरे से बात मत करो, मेरे को नहीं समझ में आता है. यू टेल मी, आई ऑल्सो नो इंग्लिश. यू टेल मी why this happened.
मैम, मुझे जो समझ में आया है, आप इस टाइम पे बहुत गुस्से में हैं. आई एम रियली सॉरी आपको इतना वेट करना पड़ा है. एंड I would just like to reassure you that we're going to look after your mother. उनको कोई तकलीफ नहीं होने वाली है.
मैडम, वो इतनी देर से बैठी हुई है, उनको बैठने को जगह भी अभी मिली है. वो तो एक आंटी जो उठ करके गई तो बैठने को जगह मिली. आप लोग बैठने को जगह नहीं देते हो मैडम. ऐसे कोई काम होता है? ऐसे बूढ़े पेशेंट्स को आप लोग ऐसे रखते हो?
आपकी बात ठीक है, किसी को भी ऐसा ही लगेगा. आई एम रियली सॉरी अबाउट इट. आई अपोलोजाइज. एक क्रिटिकल पेशेंट थे जिसकी वजह से थोड़ा डिले हो गया है, बट वी आर गोइंग टू गिव 100%.
मैडम, सब क्रिटिकल है, पैसा जो देता है वो क्रिटिकल होता है. हम यहाँ पैसे देकर के आए, हम फ्री में नहीं आए.
हाँ जी, नहीं, आपकी बात बिल्कुल ठीक है. अगर मैं आपकी जगह होती मुझे भी ऐसा ही लगता. But I'm really sorry. अगर आप अब मुझे अलाउ करो, I would like to examine your mother and make sure that she gets all right soon. Is that okay?
ये मैडम, वो पेशेंट को पहले आप बाहर निकालो जो अंदर गई है. वो अंदर कैसे गई, पहले उसको बाहर निकालो, फिर मेरे मदर को अंदर लो. पहले उसको बाहर निकालो, और ये बंदे को, ये इसको भी बाहर निकालो. मेरे को दूसरा बंदा चाहिए यहाँ पे, ये नहीं चाहिए.
इनको मैं बाहर भेज देती हूँ. बट इस टाइम पे सबसे इम्पोर्टेंट ये है कि हम आपके मदर को एग्जामिन करें ताकि उनके जो भी तकलीफ है वो दूर हो जाए. तो क्या हम पहले को कर सकते हैं?
हाँ ठीक है, पहले आप मेरी माँ को लीजिए अंदर.
आप आप पानी पियेंगे इतनी देर? Shall I ask for some water for you? Okay.
माँ को दो, माँ को.
Okay, thank you so much.
I'm sorry, Samira ji, I was speaking in Hindi, but this is the typical scenario.
No problem. Thank you so much. So Gurleen, what do you think? What did you effectively? What skills did you do effectively?
Oh, I need to process, I think, for a minute, and then I'd be able to remember, because I was just so stunned by the fantastic acting of Dr. Santana. So I think I labeled the emotion. I also apologized. I acknowledge that it must be uncomfortable and very challenging for them to be in this position. I'm not sure if I was able to. I think towards the end, she reluctantly agreed for me to examine her mother, for me to allow her.
Yes. Yes. Thank you. Thank you so much. Santwana, as a patient, what was your feeling?
As a patient, ma'am, what I felt is the doctor was quite composed. She was generally, what happens is the moment a patient is furious, a couple of sentences the doctor will try to speak will be soft, but then they tend to move slowly towards a bit of aggression, or they ask the attendant to manage. But this particular clinician was standing by me. She was listening to me. She could understand. And since she was composed, I think so my anger started coming down slowly, and I became cool. And especially when she asked the last sentence, when she said that, would you like to have a glass of water, was something which I really appreciated.
Yes, I agree with you. Thank you so much. Now we come to the observers. If Gurleen don't mind, can I ask the observers? Thank you so much. So Poonam, what is your opinion? What she did effectively regarding your task, naming the emotion and acknowledging patient's feeling?
She was quite patient about listening, but she was too soft to listen all the things very patiently. She should have been a bit stronger.
Sorry, we want just to mention the feedback which reinforce what she did effectively. If I ask you about the constructive feedback, then you can answer me. Is it okay?
Yeah.
So just focus on the thing that she did effectively.
She did effectively.
Yes.
Okay. She was patient in listening. She acknowledged the emotions of the patient's relative, family members.
Yes.
Acknowledgement was there. And then she was reassuring her that we will take care. And throughout the time, she was smiling, quietly listening.
Yes.
These were the positive points, and reassuring the family members that we will take care, we will take care.
Yes, I agree with you. Thank you so much. Dr. Heyman, what about your task regarding avoiding being defensive and asking for the causes of the anger? What she did effectively?
The most important was
you can turn on your video.
Sorry. Yes, sir. Yes. First of all, thank you. It was very well. The opening staff was so nice. The most important thing was that she was able to maintain that composure and in control of the situation. So socially, she was not seen at sea, so was quite composed that way, and to that level of anger of the patient, because when the patient is not ready to listen to anything, so that time it creates a panic kind of a thing, and asking for help from the team. So that will come in other part. So what best, but she stood her ground. So that was a job well done.
Thank you so much. Beauty, please. What about your task of observing, acknowledging patient's view and skills of attentive listening? What she did effectively?
So I think 1 minute. Sorry. So I have some internet issue. I've connected from both my devices. I was able to hear both sounds. So she did touch upon the aspect of acknowledging the patient view. I think she could have spent a few more lines, like a few more seconds on that, especially on the points where the patient mentioned that somebody else has been taken in and I'm being made to sit outside. And there's some issue, and then the other person who's like consuming tobacco in front of in front of the patients. So that kind of, you touched upon it, so you did a good job of that. I think you did not totally solve it for the patient. I mean, the patient would have still gone with the mindset that these kind of things are taken, I mean, they are okay with the hospital. So that may be, but otherwise you did a great job. I got disconnected right at the end of the entire discussion, but you did a great job the entire time. You were smiling a little more than required, maybe because we are doing a role play and you couldn't, and the way Dr. Santuna just came at you. But other than that, brilliant. I loved it.
Thank you so much. Rinoka, please. What she did effectively regarding asking the patient's perspective for solving the problem, and whether she offered her view for solving the problem, and whether she thanks the patient or not.
Yeah, thank you. First of all, appreciate the Bollywood performance. It was very nice from both of you. Really good to see that. And yes, coming down to the point, yes, she did go from the patient's perspective point. She did understand, and she also told in the particular terms, like, you know, if I was also in this position, I would have felt like that. And she also gives the solution to solve it. Like she says, like, I'll send this patient out, and then, you know, say take you and take your mother in for the treatment. I don't effectively remember her saying thank you, but it was by way of a different gesture of offering water, or, you know, kind of assuring the patient I mean the attender, and then calming the whole situation. So I think the 3 points were covered effectively in that way.
Thank you so much. Shall I continue, or shall I ask about the construct feedback, or no need?
Two more things I want to point it out in a constructive feedback. She didn't lose temper, one thing. She was quite patient and listening to it. And secondly, she didn't call any other team member for help, which is most of the time we call other team, isko sambhalo, ye chilla rahi hai. We call other team members or other security staff or help people to handle the patient and other relatives, which she didn't. She managed the whole show on her own. Gurleen. These 2 points were also constructive in this role play.
Thank you so much. Okay, so Gurleen, what do you think? What would you like to do differently?
I think Dr. Beauty was, I could have rotated my explanation more. I think not about is it
अभी तक अच्छा चल रहा था, इंटरनेट अटकने लग गया। हो गया, सोने का टाइम हो गया।
Beauty, please mute your
लिंक है तो अब आया है तो अपना लैपटॉप चालू।
Gurleen, I think you're on mute.
I'm sorry, I kept on talking.
I had to mute everyone. Noise. I was not able to tell you, please unmute your device. Sorry.
No, it's no problem, ma'am. Ma'am, the first one where I felt that I could have explored the carer's perspective in a better way. The second was not addressing the staff engaging in an unprofessional conduct. I think that should have been addressed as well. And I did not thank the patient towards the end. I should have done that.
So can I add a point here, Gurleen? Am I audible? Yeah. So Gurleen, in such a situation, sometimes thanking becomes more like, you know, it may not go well with this situation sometimes. I mean, it's all right if you have not thanked her, because she hasn't given you a compliment or so, but your good behavior covers for the reason that she's upset for, and you kind of addressed her concern and resolved the issue. So that's I think enough. So we don't have to apply everything everywhere. The idea is wherever it is applicable, we should be practicing that skill. But at this moment, I can't say, Santwana, thank you so much. You created ruckus at my place and you made a big scene at my place. I wouldn't be thanking her. So I think we got to see if that is applicable or not in that situation. Yeah, please. Like
Ma'am,
that.
seeing the
Dr. Samira should be, yeah.
I have a question.
Yeah.
About the feedback of Poonam. She said she didn't call another one. So is it one of the skills of dealing with angry patient to call another one?
Yeah, here in India, we do this. We call the safety, security people sometimes to handle the patient or relatives themselves instead of giving. Yeah.
But if it reach it become advanced, if you feel that you cannot
If it
control
would have been more volatile and all, then she could have taken the help. But it was a normal communication between the patient's relative, and she was handling it on her own. So she took the charge of the complete situation and handled it herself.
If you are calling security for the purpose of
safety,
perfectly all right.
But here it was not required actually. She could handle it herself. But initially also, sometimes we call many people, and instead of solving the problem, it flares up sometimes. I feel we call the security people, इनको संभालो, इनको साइड में ले जाओ, इनको देखो क्यों ये चिल्ला रही हैं, क्या हो गया इनके साथ अभी. Sometimes we behave like this also. There are situations in which we behave differently.
What I'm saying, if you're calling security for the purpose of your safety, especially when you can sense some kind of aggressive reaction coming from the family, is perfectly all right, because safety is first. But if you're calling security for the purpose of escaping the situation and throwing the ball on the security staff to manage the show, then it can aggravate the situation and things can go out of control. So one is really careful in choosing when to call the security, and also security should be only intervening when they actually see the family becoming aggressive or physically assaulting the healthcare provider. Otherwise, they just have to be around, and I think their presence can also help control the situation, because the family would know that there are people who can control us. So they are less likely to be physically aggressive. But they should be very clearly instructed not to interfere till it is really required to. Yeah.
Yes.
Right. This was my perspective also.
Thank you. Thank you so much. Thank you for all of you. I think my time finished.
Wonderful.
Wonderful. It was really, really good.
So I think everybody will have to give your feedback about the way Samira did her role play, and then what is the learning quickly. One line just quickly, and then we move to Santwana.
Samira, madam, involved each and every participant into the entire activity of role play by giving them certain tasks, which is very important. So all of them were attentive.
Yeah, very good.
Explained everyone about their part of observation, which was very good. Generally, people think that she will say. She specifically told everyone that you have to observe this particular skill, which was a great thing on her part.
Wonderful. Wonderful. What about others?
So she made Gurleen feel comfortable and not judged. So that was brilliant. That's very important and critical in conducting role plays.
Very important. Yeah, very important. What about others?
Ma'am, I saw the same thing you did when I came to attend your session. That you made sure that there are few participants who were task was given and they were observing the particular task and they had to review and they They would tell what exactly was done and what was missing. I could really relate to it.
So for you, it was more like repetition, what you had seen me doing in the. Yeah.
Yes. Yeah.
I use the
I
same.
have seen now the role play and how do you exactly do in the real setting.
Exactly. So
Now
you
I
have
could relate that. Yeah.
try doing it in the same manner, the way Dr. Samira has, given you a demo, and you will find it very, very meaningful, and it is very useful tool in, and Gurleen, how did you feel doing that role?
I think ma'am was, she explained it really well. She sort of, her explanation was in chunks and she kept checking for understanding, not just for the role players, but also the people involved in giving feedback. I think that helped a lot. The attention to detail, right from turning the cameras off so that the focus, everyone could review. I mean, everything was executed. It was a very transition from one stage to another.
Role of a doctor. How did you feel doing the role of a doctor?
I felt quite comfortable, even though I'm not a doctor, I'm not a health professional.
Or like, could you see things from their point of view? How sometimes in tight spot you feel when the patient becomes aggressive, and actually how difficult it is to handle that situation?
100%.
So this is how you get to see the other person's perspective. Role plays help us to see things very closely and observe the behavior and also our own abilities to handle that situation. So when I use this tool with my students, medical students, they get to realize that, okay, this we are not able to handle it. That means how will we handle in the real life situation? So role play is a wonderful way to give you an opportunity to reflect on your, capabilities and your, ability to handle this situation. So any last minute? Yeah, Dr. Hemant. Yeah. And Dr. Renu. Yeah.
Yes, ma'am. Everything was so nice. Ma'am, I just had this feeling, okay, this is like we can allot the observing part. So what happens actually when you are allotted that particular activity, so your focus of area remains to that activity, and rather than the whole part. So if we could have, like, we could watch everything like whole scenario, observe things. And because we have those people who are sitting there are to learn every single thing from emotion to activity to, so you have to got to have a holistic approach, and then we can answer on that thing. This is my just view, ma'am. I feel ki more of a task giving, though my focus will be on, and we can have a whole picture along.
But if you don't assign the task, it is observed people are not able to give a very, a concrete feedback. They will usually come out with, oh, she really did well. I think she really was, I really found her very impressive. So they are not able to give very specific feedback that one should be giving. So that's why having very specific tasks for the observer is one, you are able to engage them. And also you are able to give them a task and learn observation. Learning how to observe. Even that's an important thing.
Ma'am, another thing which
Please.
Which I found, like the patient, Dr. Santuna was saying in a very rustic kind of thing, and the doctor was in a sophisticated, more of, and using the language, the English, more of English, and the patient was more of a Hindi kind of. So can it be like medium of communication according to the patient also can be the point?
That has to be the same language. Only then communication will happen. Otherwise you are on a different page and the patient is on a different page. That's very important. That's very, very important.
She speak in English because for me to understand.
Actually, I'm so sorry. I realized it quite late that I was talking in Hindi all this while.
No problem. It was
and
very
Samira
nice.
must be wondering that what's wrong, what's going on, what are they discussing?
I think it comes from your personal experience of being a patient. Everything has come out.
Ma'am, this is thanks to the TV series where I'd acted in, and I've seen all these things happening. So I'm so used to all these acting things.
You went into the role. You went into
ma'am. Yes, ma'am.
That's why you were speaking. Dr. Samira, you were saying something.
I want to mention one thing also, but because there was a shortage of time, I didn't mention. Before starting the role play, I, as a facilitator, I should explain to my learner or my participant that the feedback during giving feedback, you should focus on the feedback which reinforce what have been done effectively. Not the corrective feedback. This is very important point to mention it before beginning the role play. Thank you so much.
Ma'am, just to add from my side, I think Samira ma'am took the lead from the beginning. Even in the WhatsApp group, she was very active and posting, I was suddenly seeing so much activity on the phone, and it was a good learning thing. And
She was really preparing very well for her role.
yeah, it was a right fit, I think, too, and a good start for this facilitation session.
Wonderful.
Thank
So it is
Thank
10 past 10, and Santwana, you are starting now your activity. So
No.
let's.
Ma'am.
With the kind permission of all, Renuka ji doesn't seem to be.
I get up
having
at
much-
4:45. So today, because tomorrow is Christmas week, I came a little early, like by 6 o'clock. Otherwise, I would have landed straight at 8 o'clock on the table. If it's okay.
So, ma'am, as you suggest, ma'am, whatever. Dr. Indu, ma'am, whatever you say.
I think we can do it next time, Santwana.
Yes, ma'am, sure.
No
Sorry, ma'am. Sorry if I'm.
No, ma'am, it's all okay.
We are all here to learn. It's perfectly all right, and we are there for each other.
No, I don't want to dampen anyone's spirits.
No,
I think
not
I'll
at
sleep
all,
off otherwise after some.
We're ready.
No, we all need to be comfortable and be a part of it when we are.
Sorry. Yeah.
Yes,
Thanks. Thank you.
absolutely fine.
Is ever ready. So she can, in the middle of night, do your role play, and she can do it. I just asked this thing from you, and I want feedback before you leave, because I see feedback gets delayed, and then I don't get the real feedback, because if you will have to spare those 2-3 minutes. So how do you find this way of doing this program? Are you okay with the idea what we are doing?
Yes, ma'am.
Yeah.
Ma'am, everybody is getting involved in it, ma'am.
Yeah, I think now the whole process is coming into.
I'm not sure if how many of you are really using role play as a tool to facilitate your program.
I do it, ma'am.
Yeah, I'm sure you must be doing it, but not all of us.
Not all in a 1 hour session, no. But maybe later this thing, when we had programs, week-long programs and all for quality month, then we had done. Not in a 1 hour session, but I think in the future definitely will.
And also not in that structured manner.
Yes, not in the structure, definitely. Yeah.
Not in that structured manner. So I think that's the purpose, that we want to understand these pedagogies in detail so that we can bring that in our way of facilitating the program. Either healthcare communication or quality implementation or anything. It could be anything. But if you will be able to learn the right technique of doing it, then you will be able to integrate it with your training programs. That's the purpose. But are you okay with the idea we have designed it, that you will be doing different pedagogies in every session? Two of you will be doing. They're okay with that?
Perfect, perfect.
Thank you.
Ma'am, one kind request. It's just on a personal note. It will be nice to connect to everyone on the social media. If anyone is on LinkedIn, I'm on LinkedIn and Facebook. I go by name Renuka Vidya Shankar. So I would please do connect, or I would also, ma'am, I think you are our common point. If you can.
Definitely. And I would request all of you to, start posting this, that you are doing your master trainer program, because this is pitching for you. This is pitching for you.
Ma'am, if you can share that group photo, then we can share it across.
I'll
that can be a good way of saying that we are into this. Yeah.
Sure.
And we can build that network, no? Like we can build.
Definitely. Yeah. And we can tag each other. So
that will be fine. It's great.
So I have shared the feedback form. You can.
Ma'am, even that, okay, I'll do this. I'll see the last time I couldn't still submit, that it was not opening. I'll definitely try this out. And
now I have shared, so it will take you 2 minutes and finish it off. I decided last time, I said, no, I'm not sending in the WhatsApp group. It has to be here, right here. So I think it's working for all of you. If you could see. Are you able to open?
Yes, ma'am. Yes.
Okay, great.